right, now we're going to cover the diseases of the respiratory tract. So when we're looking at the respiratory system, we can divide it into two different areas. We have the upper respiratory tract and we have the lower respiratory tract. The upper respiratory tract consists of your nasal cavity, your pharynx, which is your throat, and your larynx, which is your voice box. So your upper respiratory tract is everything above this point, right here where your throat vibrates due to your voice box. It's everything above that. So when somebody says you have an upper respiratory tract infection, it means the infection is up here. On the other hand, the lower respiratory tract is going to be your trachea, also known as your windpipe, down into your primary bronchi and then into your lungs. So again, if you're told that you have a lower respiratory tract infection, it means that it's lower in this system. So with this system, we're going to include the middle ear as well as the sinuses. The sinuses are lined with mucosal membrane and they drain into your nasal cavity. Now there is some normal flora in the upper respiratory system. It's going to act as part of the defenses that are present, which includes also hairs, the mucus. Okay, the mucus helps capture things, as well as what we call the ciliary escalator. The ciliary escalator is the cilia on the cells that are in your respiratory system that are going to sweep stuff up to get it up and out of your lungs. Now, this is going to continue as we move down the respiratory system until we get to a certain point. Okay, and this is what's going to cause it to virtually be sterile. So we're going to look at the upper respiratory tract bacterial diseases first. So if you recall, when we add itis to the end of anything, it means that it's dealing with inflammation. So we have what we call pharyngitis. This is going to be inflammation of the throat. Laryngitis is going to be inflammation of the larynx. Tonsillitis is inflammation of the tonsils. And sinusitis is the inflammation of the sinuses. Now, these are all typically self-limiting. We also have epiglottitis. This is going to be the most life-threatening. Now, why this is considered life-threatening is that it covers this, the epiglottis is what covers the trachea when you swallow. So if this is inflamed, eventually it's going to cause you to potentially aspirate. So looking at the bacterial diseases, we see that we can have strep throat. This is the strep pyogenes, the strep or the group A strep, also known as gas, the scarlet fever. We also have the diphtheria. Diphtheria is caused by Corynebacterium diphtheriae. We also see otis media, which is a middle ear infection. This middle ear infection could be caused by Streptococcus pneumoniae, Haemophilus influenzae, Moraxella catarrhalis, and Staph aureus. So let's look at the Streptococcus pyogenes first. This can cause strep throat, also known as pharyngitis. And so when we look here, it causes inflammation of the throat region. Now, if you'll recall, this is going to be a gram-positive bacteria, and if we're collecting it from bodily fluids or broth, it will have the strepto or chain-like structure. With the lab ID, we also can see that this group is also beta-hemolytic, okay, meaning that it's going to do hemolysis to red blood cells, and it is also sensitive to bacitracin, which is marked here in that A disc on this plate. We see that this is called the group A streps, or also gas. This group does have some virulence factors that helps it with its ability to infect us, and this includes the fact that it's encapsulated. It also produces streptokinase, which is a fibrinolytic type of enzyme, meaning that it breaks down clots and potentially prevents them from being formed. We see that it also produces streptolysins. These are cytotoxic to red blood cells and white blood cells, meaning that they destroy those cells. Now, symptoms include local inflammation into the throat, fever. It also could cause tonsillitis if they gain access into the tonsils, swollen lymph nodes, and it could also progress into a middle ear infection. So with a diagnosis, we're going to do some rapid screens and or cultures. And so what we have to do is we have to swab the pus on the tonsils at the very back of the throat. This is then going to allow us to use a rapid screening that can be done with a reagent. This is known as an EIA, also known as an enzyme immunoassay, and it makes it where it goes very quickly. It will change color and let us know that strep is present. However, if we culture it, the culture is going to take about 24 hours. The treatment for Streptococcus pyogenes is going to be penicillin. Continuing on here, Streptococcus pyogenes can also cause scarlet fever. The symptoms of scarlet fever are red skin rash, and this is due to erythrogenic toxins that are produced. The toxin causes an hypersensitivity reaction. This hypersensitive reaction is a type of allergic type of reaction. It also causes a high fever, inflamed throat tissues, and one of the main cardinal signs of this is what they call the strawberry tongue. The treatment here again is penicillin. If it's untreated, it could result in more serious conditions that could ultimately affect the heart, which we saw earlier, where it can cause damage on the valves, as well as the kidneys and other body parts, depending on where it circulates to. Corynebacterium diphtheria is also known as diphtheria. This is a highly paleomorphic clubbed gram-positive bacilli bacteria. It is also non-spore forming. This is a childhood disease, and the symptoms include things like sore throat, neck swelling. The respiratory passage starts to develop a leather-like membrane. Till 1935, this was the leading killer of children in the United States. The more virulent forms do produce an exotoxin. This exotoxin can start to damage organs. This can cause heart and kidney problems, which can ultimately be fatal. Treatment includes antibiotic therapy plus antitoxins. The antitoxins are trying to take care of the toxins so they don't damage the organs. There is a preventative measure when we look at immunization. In the DATP or DTaP vaccine, it has the toxoid that's against the exotoxin produced here that causes diphtheria. Now, this particular vaccine not only treats diphtheria, it also helps treat the exotoxin of tetanus and pertussis. The antibiotic treatment can actually control the growth of bacteria, but it does not limit the but it does not neutralize the toxins. This is why the antitoxin must also be given. All right, so when we look at odious media, this is a middle ear infection, and children are at the highest risk for these. The reason they are is when they're younger, their eustachian tube, which is the connection between their ear and their throat, is narrower, and so when we look at odious media, it does, middle ear infections affect about 85% of children before the age of 3. There's over 8 million cases of ear infections per year. Now, these ear infections can be caused by a number of different bacteria, and so the first one listed here is Streptococcus pneumoniae. This is going to be located down here at the bottom, down here with A. If you recall, remember this is a gram-positive bacteria and has the coccus shape. We also see the Haemophilus influenzae. This one is going to be located in this corner. If you recall, remember this one is a fastidious type of bacteria. It does require certain growth factors in order to be present, in order for it to grow, and these growth factors are normally represented with that X and the V, known as also the Roman numerals 5 and 10. We also see that this is going to be a gram-negative bacteria. This group makes up about 20 to 30% of ear infections. Now, Moraxella catarrhalis is going to be located over here in this corner. This one is also a gram-negative bacteria. You can see that it's stained here in pink. You'll also see that this group is oxidase positive, meaning that it does do aerobic respiration. The last one's the Staphylococcus aureus. This one is going to be located in this corner, and remember that this is going to form the clusters, a gram-positive cocci bacteria. It also is going to be catalase positive, thus the bubbles, and it's going to be a coagulase positive with its coagulation. There's certain tests that you'll be learning in lab that will also help you be able to identify the different types of bacteria. So the antibiotic of choice for ear infections is amoxicillin. So now we're going to look real quick at the upper respiratory tract and the viral diseases. The main viral disease of the upper respiratory tract is going to be the common cold. The common cold is caused by two different types of families of virus. These are the rhinoviruses and the coronaviruses. There are more than 200 different viruses that can cause the common cold. 20 to 30% of them have yet to be identified. The symptoms of the common cold include sneezing, nasal discharge, congestion, coughing. The main way that we can treat these is we're just going to treat the symptoms with over-the-counter medications. We cannot treat them with antibiotics since these are a viral infection and not a bacterial infection. Now we're going to move down into the lower respiratory tract, and we're going to look at the bacterial diseases. So with the bacterial diseases, when we go deeper into the lungs, we can see things: whooping cough caused by Bordetella pertussis, tuberculosis, which is caused by Mycobacterium tuberculosis, and also the pneumonias. These pneumonias are talked about in a chart on page 691. So let's look at Bordetella pertussis first. Again, this causes whooping cough. This is primarily a childhood disease. The transmission is through airborne droplets. There is a very virulent form, and this is going to be the form that contains capsules and also produces toxins. Now, this is going to impede ciliary action, so it causes that ciliary action that's supposed to help get it out of there to not work, so it settles down into the chest. The first stage has cold-like symptoms, but as it moves deeper down into the lungs, we get into the second stage. This is going to be causing paroxysms of violent coughing for up to 6 weeks. This is also going to cause a high-pitched whooping sound, thus its name for whooping cough. This nasal pharynx swab is going to go down the nose into the throat, and then the patient has to cough. This is then going to have to be cultured on special media. This is a gram-negative coccobacillus, and it is a strict aerobe, meaning it requires oxygen. That's why it likes the lungs. We can use a PCR method for an ID, and this is done a lot of times in infants. We see that treatment is through antibiotics upon onset. Erythromycin is the antibiotic of choice. Once we're to the second stage, it only helps with the idea of transmission. All right, and so it prevents the transmission from other individuals. There is some preventative measures through immunizations. This is the DPT vaccine, and this uses killed pertussis bacilli, and it's an older version. The DTaP vaccine, the DTaP, is an acellular bacterial fragments, and this is the newer form. We also see that you can do the Tdap, which is a booster for adolescents and adults. And the booster is there to help boost your immune system to be able to fight it off better. Now, recently at my daughter's school, she was in kindergarten, and we saw that there was actually a pertussis whooping cough outbreak at the school. It did not affect the younger children, the kindergarten, first grade, because they had just had this booster shot before they went into school. But it did affect the 4th and 5th graders who were about to get a new booster shot before they went into middle school. So we do see our immune system starts to get kind of almost lackadaisical or lazy, which then means we are more prone to being able to catch it again. However, it's not as life-threatening the older that we get. A lot of times it's controlled just based after the flu-like type symptoms or cold-like symptoms. The next group is the Mycobacterium tuberculosis. This causes tuberculosis. We see that in this particular group, we have to use an acid-fast type of stain, and it is positive. And the reason for this is it has large amounts of myclonic acid. This means that it retains that carbofluorescent stain after an acid alcohol wash. This is a very slow growing bacteria that's in rods, a bacillus. We do see that they start to produce what looks like filaments, and it almost appears as it grows in clumps as a fungus. The transmission is through respiratory droplets. When we do a lung pathology, we see that it can create what we call tubercles. These are soft nodules that form in the lung tissue. These then start to calcify as they heal, which we call Ghon's complexes. Miliary tuberculosis, also known as consumption, is where the tubercles continue to grow. The lesions will rupture, which then releases the microorganisms into the bloodstream. This causes more issues because then it spreads into other body organs and it starts to become systemic. This type of infection elicits the cell-mediated immune response, which means that sensitized T cells. This is why we can do what we call a TB test, which we do the tuberculosis test, where you go into the doctor, they put a dead version of the bacteria into your arm, and then you come back a couple of days later of the reaction. If you have a reaction, then your body has been exposed to tuberculosis before, and your immune system has potentially fought it. This lets us know that you are TB positive. On the other hand, when you have a negative test, it means you have not been exposed. Now, some people actually do false positives, and this is why it's followed up normally by a chest x-ray to look for these nodules. These nodules will be present if you've had tuberculosis before. So treatment for tuberculosis includes multiple drugs, a minimum of 6 months. This is to prevent resistant strands. This is what we call the first line drugs. Isodonacide, the ethambutol. We also see rifampin. The screening, though, is going to be using the tuberculin skin test, or the PPD. This is going to have the delayed cellular hypersensitivity reaction. It does not indicate an active disease. It just means that you have had it before. We then see, to diagnose it for sure, we have to do the chest x-ray and a sputum culture. The sputum culture is going to, again, be using the acid-fast stain in order to identify it. Now, these cultures do need a special media, and it does take up to 6 weeks. And the reason for this is because they are so slow growing. We also see that the media that it uses is called the Lowenstein-Jensen, and this is an egg-based media. We see that this is a co-infection that's on the rise with HIV patients. There is some prevention or immunization that can be done. This is called the BCG vaccine. It is one of the oldest vaccines that we have and one of the safest ones out on the market, but it does give a positive PPD test. The reason for that is because you are producing antibodies against tuberculosis. Now, this is prepared from bovine tubercle bacilli. All right, now looking at the bacterial diseases, when we're looking at the pneumonias, we have the Streptococcus pneumoniae, which is known as the typical pneumonia. This is about 2/3 of the cases of pneumonia. But then we have the Haemophilus influenzae. We also have the Mycobacterium pneumoniae. This is primarily an atypical pneumonia known as walking pneumonia. Legionella pneumophila, which is found that has a water reservoir. This is also known as Legionnaires or Pontiac disease. We also have Chlamydophila psittaci, which has a bird reservoir, as well as Chlamydophila pneumonia, which has a human reservoir. Coxiella burnetii, also which causes Q fever. So guys, if we look here, there's the community-acquired pneumonia known as CAP. Typical pneumonia is about 85% of these cases, and the typical organisms that cause the typical pneumonia are located here. We see that the Strep pneumoniae is going to be penicillin sensitive, and there are some resistant strands that are out there. Haemophilus influenzae is going to be ampicillin sensitive, but there are some resistant strands. The Moraxella catarrhalis has all strands are penicillin resistant. On the other hand, you have the atypical pneumonias. This is about 15% of the cases. These are atypical organisms. This includes the Mycoplasma pneumoniae, the Chlamydia pneumoniae, Chlamydia psittaci, and also the Legionella pneumonia. We also see that some of these atypical pneumonias are caused by fungal pneumonia as well as viral pneumonia. Now, atypical organisms are not revealed on ordinary gram stain or cultured media. So taking a look here at the Streptococcus pneumoniae, this is also known as pneumococcal pneumonia. This is going to cause potentially middle ear infections, as well as could cause meningitis and sepsis. This is a gram-positive bacteria. It does have pair diplococci. This makes a form of what looks like lancets. We also see prevention can be used with conjugated vaccines for some of these types. The symptoms of this pneumonia is going to be fever, severe chest pains, and blood in the sputum. Treatment is aggressive penicillin therapy. In Haemophilus influenzae, this is, remember, a tiny gram-negative coccobacillus. The symptoms are similar to the streptopneumoniae, but when we look at this, the treatment is going to be using cephalosporin. If we recall, remember, this is a fastidious bacteria, a blood-loving bacteria. It's going to be very picky, meaning it has to have certain growth factors. And also recall that this is the one that smells like dirty socks. Mycoplasma pneumoniae is an atypical pneumonia, also known as walking pneumonia. This one is exceptionally small. It's what we call a submicroscopic bacteria. The symptoms here are more of a mild pneumonia, up to about 3+ weeks, so it lasts for 3 or more weeks. These guys lack a cell wall, so penicillin is useless. So recall when we talked about penicillin in the antibiotic chapter, that penicillin is going to attack or put holes in the cell wall. It's not going to work here since they don't have one. So the treatment for this is going to be using tetracycline. The problem is, a lot of times this one is going to be misdiagnosed as a viral type of pneumonia. So we need special media with horse serum and yeast extract in order to grow this, and colonies have what look like a fried egg appearance. The Legionella pneumophila, this one is going to be Legionnaire's disease, or what we call Pontiac disease. We saw that this was an outbreak in Philadelphia in 1976. It is a gram-negative rod. The reservoir is in water. It is transmitted via aerosols. The symptoms are a high fever, lung consolidation, and pneumonia. When we look at the aerosols, a lot of times it's found in whirlpools or especially in air conditioning units. The water lines in hospitals are a culprit sometimes for this as well. And this is what happened with the American Legion group. They were exposed to it due to an air conditioning vent. The treatment is the treatment for this is erythromycin. So when we look at some miscellaneous bacteria, we saw that there was the Chlamydophila psittaci is going to be a bird to human transmission. This is also known as psittacosis or ornithosis, meaning that it travels from birds. We also have the Chlamydophila pneumoniae. This one is going to be from human to human. This is also known as chlamydial pneumonia. We also then have the Coxiella burnetii. This is going to go from mammal to human, and normally the mammal that it comes from is goats. This is also known as Q fever. We then see chick transmission to the mammal reservoir that takes place here. Complications of Q fever include endocarditis. And so when we're looking at intracellular bacterial parasites, these guys have to gain access into the cells. So diagnosis is going to be using cell cultures or serological tests. We're not going to be able to necessarily culture them just on normal media. Now we're going to look at the lower respiratory tract with the viral diseases. So when we're looking here at the viral diseases, we have things like SARS. SARS has emerged but is also limited to Asia in 2003. This is known as severe acute respiratory syndrome coronavirus. This is what we also term as viral pneumonia. We also have respiratory syncytial virus or RSV. This is seen in infants. All children are exposed by 2 years of age. It can cause a life-threatening pneumonia. It does cause about 4,500 deaths per year. And the diagnosis for RSV is using a serological test. We also see influenza. This is going to be the flu. This is the influenza virus. There are 30,000 to 50,000 deaths per year from influenza. So looking at influenza, this is the flu. The symptoms that come along with the flu are going to be chills and fever, headaches, and muscular aches. The treatment that we see that we have to use for the flu, since it is a viral infection, are antivirals. You'll notice that the flu virus is a enveloped virus. It's an enveloped RNA virus. It does contain what we call it can contain HA spikes as well as NA spikes. The HA spikes are the hemagglutinin, and these help attach to the host cells, and they're shown here in the gray. The NA spikes are the this is going to allow it to release from the host cell. These spikes are used to serologically group the different viral strands of the flu. This is why you end up hearing about flus that are H1N1. It's talking about the H type of spike as well as the N type of spike. So when we're looking at type A flu, if you go to the doctor and you get diagnosed, they say, oh, you have type A influenza or type A flu. It's normally moderate to severe illness. All age groups get this, and humans and other animals can also carry this. Influenza A is a human-adapted viral subtypes causing pandemics, and this is the group that actually has more of these, what we call like the H3N2, also known as the Chinese flu. We also have the H3N flu that came back in the Hong Kong area. We have the H2N2, known as the Asian flu. The Spanish flu, we believe, has mutated a little bit into H1N1, and this is also known as the swine flu, or the what we see in Mexico. So these are going to be the ones that we see that antigens start to shift with these different mutations in the H and the N. Now, type B is a milder disease. It primarily affects children, and it's only found in humans, so it does not come from other animals. Whereas type A, from other animals, we see it could come from pigs or birds. Type C is rarely reported in humans, so there's no epidemics on record for type C. So prevention, the flu vaccine, we see is 70 to 90% effective for about 2 years. The thing that's the issue, though, is they have to do a prediction of which type of flus are actually going to be the problem. And this is what they pack in the flu vaccine. They can't put all of the different subtypes in there. This would make it where it would just be too much for the body to handle. So I have to guess. So sometimes it's more for a particular flu season, it works better than others. We see that there's some antigenic shift that takes place. We saw that down on the chart on the slide before. This is where there's some genetic recombination that happens. This means that we start to see different variations. The RNA inside the virus starts to change over time, a type of mutation. This could be due to picking up pieces of DNA or just changing due to mistakes. This is responsible for some of the pandemics that we see. The changes allow the virus to invade the body's immunity and makes it harder for our immune system to fight it off. We see that a lot of times we see the avian strand comes from wild birds, but it can then be transmitted to chickens and then on to pigs. This is going to be where the pig is the mixing vessel. This is where we actually see that you can see a mixing of mammal and avian, which is bird strands. Generally not infected by avian strands as humans. However, when we have a mixture of the two that come from pigs, we can be infected. Some examples of this is the H5N1 as well as H7N9. Now note, recombination most likely to occur in areas of Asia where domesticated poultry and swine are raised in close proximity. All right, so they're raised in close proximity, so we see this more often in Asia. This is one reason too why we use Asia as a way to kind of predict what potentially will happen, because we see some of those shifts and changes earlier over there than we do in other parts of the world. All right, so now we're going to look at the lower respiratory tract and the fungal diseases. So with the fungal diseases, we have histoplasmosis. This is caused by Histoplasm capsulatum. We also have the Coccidioidomycosis, which is caused by Coccidioides immitis. We also see the Blastomycosis, which is going to be caused by Blastomyces dermatitidis. We also see in these three groups, they're highlighted in blue because they are considered dimorphic, meaning that they have the two different ways the fungus can grow. Remember, we talked about fungus can either be in the filaments with the hyphae, okay, and that causes the mycelium, or it can be single cellular like you see with yeast. We also see pneumococcal pneumonia. This is going to be caused by Pneumocystis urevetsii. We also have Aspergillosis, which is caused by Aspergillus fungatus. Generally, these are considered opportunistic in the sense that they don't make us sick if we're relatively healthy. However, if a person is immunocompromised, they are at a higher risk. Transmission is through inhalation or breathing in of the spores from it being disrupted from soil. So when we look at the dimorphic fungi, this means that it will grow as a yeast if it's at 37 degrees Celsius, which is what our body is at, and it grows more at a fungus at a lower temperature at the 25 degrees Celsius. The infectious form, when we look at the fungus, the portal of entry is going to be respiratory. It's not transmitted person to person. It's a deep-seated mycosis. It may be progressive. And again, this is going to be a problem for the immunocompromised. So it's going to be spread through the soil in the fungus form, and this is how it'll get into mostly immunocompromised individuals. The Histoplasma capsulatum is going to cause histoplasmosis. This is again a dimorphic form. We see that the infection is similar to tuberculosis. Most cases are associated with bird and bat droppings, where we've been exposed to that. And the reason that we find it associated with bird droppings is that it offers, the droppings provide nutrients. We also see nutrients for the fungus. We see that the bats are going to carry this fungus as well because of their lower temperature. The treatment here is amphotericin B. Coccidioides immitis is going to cause Coccidioidomycosis. Again, this is a dimorphic. The soil is going to be the reservoir. It is transmitted in dust, so farmers are more predisposed to it due to the fact of being exposed to that dust being kicked up. It's common in the southwest, and it's also known as valley fever. The symptoms include things like fever, coughing, and general malaise. Again, treatment is going to be the amphotericin B. Blastomyces dermatitidis is going to also be dimorphic. It is found in the Mississippi Valley that we see here in the picture, and it is also spread by dust. The symptoms are tuberculosis-like lung symptoms, and again, the treatment is going to be through amphotericin B. Pneumococcal pneumoniae is going to be caused by what used to be known as Pneumocystis cranii, but it is now known as Pneumocystis urevetsii. This one we see here that it causes, we can find that there are cysts in the sputum. Chest x-rays also need to be done with this. The problem here though is that is it a protozoan or is it a fungus? We also don't know if the reservoir is in humans or if it's in something else. The symptoms cause severe consolidation in the immunocompromised. We see very complex organism with its life cycle involving mature cysts and highly resistant forms. So this is what causes us to be a little confused about what it actually is. Now with DNA analysis, we do feel like it's probably more on the fungus side. However, again, more research is going to be done. Now, Aspergillosis is happens when a fungus ball will colonize in a healed lung scar and an abscess starts to form. This is actually going to be seen a lot of times in farmers and gardeners because they're more prone from it coming from soil and getting kicked up into their lungs. Now, there is a chart over the lower respiratory diseases, which is found on page 702 in your textbook. So again, if you have any questions or concerns, please let us know.